bladder cancer, the treatment that we have here called the blue light technique. And then for prostate cancer, we're going to start an advanced prostate cancer center at the hospital, and the hospital has agreed to purchase a robot, so we'll be able to perform robotic prostatectomies here as well. So really the state-of-the-art technology for this. So what is bladder cancer? Bladder cancer, think about it's analogous to skin cancer. You're out in the sun as a teenager, and then as you get older, you tend to get a cancer in one location, and then it can come in another location. Bladder cancer is a cancer of the lining of the urinary tract. So whereas squamous cells cover the body, transition cells cover the inside of the urinary tract from the kidney to the ureter to the bladder. And it can get cancer. And what causes the cancer, there's some genetic predisposition, but also environmental factors like smoking or other carcinogens in the diet or in the environment that you may be exposed to. Risk factors for bladder cancer, the most important thing to do is to try to stop smoking, okay? Because that's really a known cause of bladder cancer. Also, chemical exposures, if you are in a job where you are exposed to aromatic means, dyes, textile, tire, rubber, leather, petroleum workers, painters, and hairdressers, that can put you at increased risk for getting bladder cancer. And then obviously, with age, the risk increases with age. 90% of people with bladder cancer are over the age of 55. So how common is it? It's really one of the most commonly diagnosed cancers, with approximately 80,000 new cases diagnosed each year. In the U.S., it's the fourth most common cancer in men and the ninth in women. There are over 500,000 bladder cancer survivors in the U.S., so it's a lot of people that have this problem. How do people diagnose bladder cancer? Well, one of the signs that you could have bladder cancer is that if you have blood in the urine, okay? And so that's a symptom that you don't, or that's a sign you don't want to ignore. If you've got blood in the urine, you need to see the doctor, okay? And also the primary care doc may also, hi, come on in, welcome. Your primary care doc may also check the urinalysis, and if you have more than 3 red blood cells per high-powered field on the urinalysis with microscopy, then you need to get screened for bladder cancer. And the way we do that is with a CT of the abdomen and pelvis and a scope, which is a lighted instrument that we use to look through the urethra into the bladder in the office. Another test that we oftentimes use for people with visible blood in the urine is called the urine cytology test. This is the way we diagnose it. Now, traditional cystoscopy, where we use a lighted instrument to go in through the urethra, uses white light. Much like any other, like the light in here, you'd shine light in the bladder. You'd see if there's a bladder tumor there or not. Okay, and certainly that's a fine way to do it, and it's been the standard of care for decades. But there's a newer approach to diagnosing bladder cancer and treating bladder cancer that uses blue light. And maybe we can hit the lights for a sec, just so I can show you. Okay, so you can see this top panel up here. This is, when we look in with the scope, this is kind of what the bladder looks like. If I were to see that, on the scope in the office, I would look and I'd say, that looks pretty normal. Now, with blue light, what we do is we put a catheter in the bladder. We put medicine in through the catheter into the bladder. That medicine then it goes directly to the cancer cells, and then when we put a scope in there, a special kind of scope called a blue light scope, and shine, it causes the cancer area to turn pink, okay? And so, that's really obvious. And we would have missed that with traditional white light. And now that we have blue light, and we offer this here at Titus, there's only 2 other centers in Texas that have this technology, MD Anderson and UT Southwestern, where they have it both in the clinic and in the operating room. So, bottom line is, if you have bladder cancer, this is an important thing to ask, your doctor or your urologist, hey, do you have the blue light? Okay. So what happens during blue light cystoscopy? This is an overview. We put a catheter through the urethra into the bladder. We deliver the solution called Cysview into the bladder. That stays for 30 minutes to an hour, and then we take you back to the cystoscopy suite. We put the scope in and then take a look. Okay. So really, can anybody get this? The answer is yes. The indication is that if you have a visible bladder tumor or known history of bladder cancer, you'd be a candidate for getting this. Okay. The next thing I want to talk about, and I'm going to do this slide deck, and then if we can switch over to the other slide deck. Can you do that? To switch to the other slide deck after this. Is prostate cancer. In the U.S., prostate cancer is the leading cancer in men, second only to skin cancer. So the most common solid organ malignancy in men, and it's the second leading cause of cancer death after lung cancer. Okay. The good news is that when we started screening for prostate cancer in the 80s, it led to an increased detection of prostate cancer, but with time, and what these curves are, these are mortality curves. So screening for prostate cancer saves lives. If you screen for prostate cancer and you treat, you're going to save lives. And the same thing has been true for lung cancer as well. So, if you look at it worldwide, in countries that they actually have screening programs, like the United States, Australia, and Canada, you can see that the death rates from prostate cancer are going down, whereas Japan and Russia, the rates are going up, or in the Republic of Korea. Let's switch over to the other slide deck. Okay. And then I want to introduce, can everybody from my office stand up? And you want to introduce yourself?
Hi, I'm Rosa. I'm the referral coordinator for Dr. Walsh's office. I'm Scarlett. I work at checkout and I'm scheduled procedures.
Hi, I'm Catherine. I'm the nurse practitioner working with Dr. Walsh.
Hi, I'm Jackie. I'm one of the managers at Dr. Walsh's office.
I love this. So, and help yourself to the refreshments if you got here a little late. There's some snacks on the side there. Okay, perfect. Okay. So, the other thing I want to talk about is management of clinically localized. So, if you have prostate cancer that we detect during a screening event, what are the options? How do you treat this? Okay. So this is, you've had the biopsy, it shows you have prostate cancer. What are the options? So this is kind of an overview for how we diagnose and treat prostate cancer. So, when we talk about screening for prostate cancer and treating prostate cancer, here are some factors that we want to know. We're looking at what your life expectancy is, what your overall health status, and also what your prostate cancer tumor characteristics are. Because you have characteristics, prostate cancer has characteristics, okay? When life expectancy is long, localized prostate cancer can progress and cause pain and suffering. When life expectancy is short, then we tend not to be worried so much about prostate cancer, okay? The overall health status determines life expectancy and also plays a role in determining the choice of treatment. So certain treatments for prostate cancer help urinary symptoms more than they hurt them. So for instance, if you have difficulty with urination and we remove your prostate, that may help you urinate better. The converse is not true. If you have difficult urinary symptoms and we radiate the prostate, that may make your urinary symptoms worse. So these are factors that we want to take into account. So the question is, okay, so I have prostate cancer, really how bad is my cancer? The way we describe, prostate cancer is that we look at three different variables. We look at the PSA level, which is a blood test that we use to screen for prostate cancer. We use the Gleason score, which when we have a biopsy and we look at the pathology, the pathologist looks at it under a microscope, they assign a grade between 1 and 5 to each area. The most common area, they'll give the first score on a grade of 1 to 5. The second most common area, they'll give the second score on a grade of 1 to 5. They'll add those up to get the overall Gleason score. And then the other thing we look at is the tumor stage, which is what we determine on a digital rectal exam. You know, if the prostate is smooth, then it's the lowest stage. If the prostate appears to be hard or growing into surrounding organs, well, that's worse. So these three factors is how we describe what the prostate cancer is. So, as I said, PSA is a protein produced by cells within the prostate. The higher the PSA is, generally the greater burden of prostate cancer. And generally, if the PSA is over 10 to 20, we get concerned that maybe some of the prostate cancer is spread outside of the prostate. That's why it's really important for the men there between the ages of 55 and 70, or men with more than a 10-year life expectancy, to get your PSA checked on an annual basis and get your prostate exam on an annual basis. It's no fun, but it could save your life. How does PSA predict outcomes? Really, the PSA level and the rate of increase are predictive of how aggressive the prostate cancer is and how much prostate cancer has spread. So, how does, people say, well, I thought PSA really didn't work that well. Well, the fact is, if your PSA is, less than 10, or let's say the PSA is less than 4, there's about an 80% chance that your prostate cancer is confined to the prostate. Let's say it's over 10, there's only a 50% chance it's confined to the prostate. And this is kind of a statistic. If your PSA is over 20 and you have prostate cancer, there's almost a 40% chance that you have cancer that's already spread to the lymph nodes. So that's why PSA is important. The other thing we look at is the tumor grade. The grade goes from 1 to 5. It's called the Gleason score. This is kind of what it looks like under the microscope. Really low grade looks like pretty well differentiated nests of glands, and then you look at this end of the spectrum is there's really no architecture, or normal architecture that you would see with normal prostate tissue. And this is what the pathologist can determine by looking at the biopsy core. Tumor stage is determined by when we do a prostate exam. And of course, here's the anatomy. This is the bladder. Here's the prostate, and here's the urethra that comes through here. And this is how we're able to screen for prostate cancer. Where prostate cancer normally occurs is in the peripheral zone of the prostate here. That's how you can feel it on the rectal exam. Typically doesn't occur in the transition zone or in an anterior space. So this is more of a technical classification. If we didn't feel a nodule on your prostate, we'd give it a grade of a clinical T1C. If we did feel a nodule, it'd be a T2. Okay, so this is kind of how we depict it graphically. So stage 1 would be prostate cancer is localized, and stage 4 would be prostate cancer that could be growing into the rectum, growing into the bladder, or growing into the surrounding tissues. Okay, so when we answer, how bad is my cancer, using the PSA, Gleason score, tumor stage, that help us define, what the likelihood of success with treatment is, what the likelihood of risk of death for prostate cancer, or with spread of cancer after treatment. So it has prognostic implications. One of the things that we normally would do is that for each individual person, if you come in with prostate cancer, we would look at all those variables, and there's a computer program that we could use to put all the numbers in, your age, etc., and it will give us the statistics like how likely is it that your prostate cancer is curable. how likely is it that you'll have a recurrence of cancer? Okay, so based on that, we would stratify prostate cancer into low risk, intermediate risk, or high risk cancer. And in addition to that, there are a host of companies that you can do DNA testing on the pathology or the specimen from the prostate biopsy to try to provide also additional information. Because over the last 20 years, when people have had their prostates removed or biopsied, they've had that specimen analyzed genetically to determine what their expression profile is. And that is associated with outcomes, how their cancer behaves. And so it's been a very important fourth thing we look at too. So, in terms of treatment options for prostate cancer, again, this is cancer that's localized to the prostate. Active surveillance is one of the top ones we use. There's also brachytherapy, external beam radiation, and radical prostatectomy. So active surveillance, when I trained at UT Southwestern, I graduated in 2007. At that time, if you had a small amount of prostate cancer that was low risk, chances are we were going to treat that. We're going to treat it with surgery or radiation, okay? Data has come out since then that shows that if you have a low-risk prostate cancer, then it's a good idea not to treat it because people don't die from low-risk prostate cancer. They don't suffer from it, okay? So what we do with people with low-risk prostate cancer, for the most part, is we do what's called active surveillance. It's not nothing. It's not doing nothing. It means active surveillance means we would do a PSA check every 6 months and an annual prostate biopsy, okay? And if we were to detect more aggressive prostate cancer, then we would go ahead and offer definitive treatment with either surgery or radiation, okay? Second thing that can be offered is brachytherapy. What brachytherapy is, it's where we put radioactive seeds in the prostate, and we do it in 3 dimensions so that each square centimeter of the prostate receives radiation at a treatment dose, and it's put in through the perineum area. Each of the seeds, and I don't know if you can see it here, they're actually quite small, and usually they come in a chain, and that chain is inserted into the prostate. And this is an x-ray that shows, this is the expected location of the prostate, this is the pelvis. You can see there's literally 100 seeds in there, maybe 150 seeds. Each one of those is radioactive. They either use cesium or iodine-121. And cesium has a lower half-life, but over time they'll lose their radioactivity. More commonly, external beam radiation therapy is used. This is an example of a linear accelerator that the gentleman would sit here, the prostate would be targeted, and generally the treatment occurs over the course of daily for 6 weeks. And the cancer center here has this linear accelerator. The dose and treatment varies according to if it's a low, intermediate, or high risk prostate cancer. Generally for low to favorable intermediate risk, you just have radiation alone. For unfavorable intermediate risk or high risk, we tend to add androgen deprivation therapy in the form of hormonal therapy to decrease your testosterone levels. For unfavorable intermediate risk, the duration of the hormonal therapy would be for 6 months. For high risk, we're talking about 3 years of hormonal therapy. Okay. All right. And then the final option that I want to discuss is radical prostatectomy, and what that involves is putting several abdominal incisions using a robotic instrument to assist the surgeon at removing the prostate. And typically a nerve-sparing procedure is performed in order to maintain the gentleman's erectile function. Also, at the same time, we can remove the lymph nodes in the pelvis for staging and treatment as well. This is what the apparatus looks like. So the surgeon sits at the console, and the patient is lying on the table here, and there's an assistant at the bedside. And what this is the actual robot itself that the surgeon controls, okay? And there are 4 arms on the robot, and the center arm here is the camera, and it allows for 3 other working arms that have special instruments. They can either grasp the tissue or cut it, or hold it in place and retract it. So it's the hospital here is really committed to bring in the most advanced robot starting in January. So this is a picture of where the port placement will be, along with the camera port here. And then this is kind of what it looks in action. You can see this is the robot itself, and it has the sterile covering to keep everything sterile. And then you have the surgeon and the assistant putting in the ports. So, the idea is there's not one shoe fits everybody, okay, with respect to treatment of prostate cancer, and really for, I'd say, bladder cancer as well, or kidney cancer. I mean, generally there are options that you should be aware of before you undergo treatment, and it's always a good idea to get a second opinion too. Part of starting this bladder and prostate cancer support group is we also started a genitourinary tumor board, where we have urologists and radiation oncologists and medical oncologists, not only here but associated with Texas Oncology, which is more of a national organization too. So if you're treated here for cancer, your care is overseen by a group of people, even though you may just see me. I would present your case at a board where we have 3 or 4 other physicians, and we go through and make sure we have consensus. And one, it's really to ensure that we're offering you the best therapy, but also, when you have different doctors from different backgrounds looking at the information, then all it does is optimize care. So one final word about the different side effects of these various treatment options. When we talk about what are the risks, the side effects or risks of surgery or radiation for prostate cancer, the main 2 are erectile dysfunction and incontinence. Radiation tends to have a host of other problems related to the bowel or gastrointestinal tract, because when you radiate the prostate, radiation behaves almost like wood. Some of it's reflected, some of it is transmitted through the tissue. Obviously, the goal is to target the organ of interest with radiation. They do that focally by moving the radiation around it, much like you'd focus the camera on a specific object. You could focus it on there, but you're still going to have radiation going to other surrounding tissues like bladder, rectum, and if you have radiation to those organs, that will obviously irritate the bladder. It can cause bleeding down the road. Same thing with the rectum. The way radiation treats cancer is it causes DNA damage, but it's not selected just for cancer. It can affect normal tissue too. So once you sustain the DNA damage, it's essentially lifelong. So you can have problems with radiation that comes up 5, 10, 15 years down the road. And so just, if you look, here's the different patterns. This is with brachytherapy, and these are various complications. Obviously they differ. This is external beam therapy. This would be radical prostatectomy. So, with radical prostatectomy, you really, much like with radiation and surgery, you get the erectile dysfunction and incontinence, but you get much, much less, bowel side effects. So generally for younger men, say less than 70, the recommended option is to proceed with surgery, and if you're older than 70 or less of a surgical candidate because of your medical problems, then radiation is probably the way to go. Okay, so with that, I appreciate you coming out here, and then what we wanted to do is kind of have a question and answer, and then also, because this is the first meeting of the support group, is what specific